final presentation, I'm delighted to introduce Dr. Gonzalo Martínez-Alés and Dr. Alejandro Szmulewicz, whose talk will focus on interventions involved in medications.
So for our talk, we're going to mainly explain why we think examining medication for suicide risk is important, which are some of the challenges of conducting this kind of research that we face in trials and operational studies. Some of these challenges have already come up in previous talks. And then we'll go over specific medications, and in particular, we'll focus on lithium, which is by far the medication with the largest body of evidence for suicide risk. So we can think of the clinical need for effective medication strategies as different clinical questions. Both Alejandro and I are psychiatrists, and the typical question that we face us in the clinical field is, first, what is the right medication to use for a person who shows up for care experiencing suicidal ideation or going through a suicidal crisis or that we deem a suicide risk? So which are the medications, or are there medications that can lower that risk of suicide in the short term for a person that is going through an acute crisis? And then there's a somewhat different question, which is which are the medications that we can use for people who are diagnosed with disorders that are associated with high suicide risk, like schizophrenia, or bipolar disorder, or depression, that can be effective for the treatment of that condition, and also be effective for lowering suicide risk for the person. The challenges we face in the research for these kinds of questions are, first, the usual challenges for any randomized, potential randomized trial with medication, and then there's first there are ethical challenges. So in general terms, this is in general terms, not always, but for beneficence reasons, research has tried to exclude people who are deemed suicidal from trials to protect them. So that leads to first problems with justice, because there's not equal access to the trials for all patients. And also leaves us with an evidence base that applies to patients who are not suicidal, because those who are suicidal are typically not included in trial. Then there's a problem of attrition that has come up with that, especially with the trial of the great time trial for psychiatry. People at suicide risk typically don't engage on treatment, or disengage from treatment. Also, the population groups with the highest suicide risk have problems to remain in follow-up, and also dropping from follow-ups is associated with higher risk. So all this is important for thinking of study design. Also, we've talked about this before. Suicide is very infrequent, so studies are typically not powered to find differences in suicide death. So we use other outcomes, potentially proxy outcomes. They might not mean the same. We talk about differences between suicidal ideation and behaviors. And last, as Dr. Mark just showed, there's a lot of people whom variation in suicide ideation is dramatic in very short times or period of times. So we need to, if we want to conduct studies, we need to have a lot of information on the time varying ideation and risk factors if we want to actually be able to identify those. So there's some medications. So psychiatrists typically use benzodiazepines or antipsychotics for short-term reduction of suicidal ideation. There's recently there have been new developments on other interventions that might be useful to lower short-term suicide risk. So I'm going to briefly talk about ketamine and buprenorphine. Ketamine is an anesthetic drug that is currently accepted for use in treatment-resistant depression, typically with an antidepressant. And at a sub-anesthetic dose, there is some evidence that ketamine can lower short-term suicide risk with a very useful, with a potentially very useful effect that lowers suicide risk or ideation in 48 to 72 hours. So this has been shown in trials comparing ketamine with midazolam and with placebo, and the thing is that they don't show to have an effect on suicidal behavior, so they just impact ideation. Samely, buprenorphine, which is a partial agonist of the opioid receptors and is used for opioid dependence. At a very low dose, this is in line with theories that suicidal ideation is can be related to something called mental pain. So using buprenorphine in very low dose apparently can lower suicidal ideation in patients compared to placebo. But again, there is no evidence that this can affect suicidal behaviors or risk of suicide. Then, for specific disorders, we have specific medications. And we start with Clozapine. It's a very effective antipsychotic. It's typically used as second-line antipsychotic because it requires monitoring because of risk of decreasing the number of white blood cells. It is the first FDA-approved drug for suicide risk, and it is mainly based on this landmark study, the INTERCEPT study, randomized trial, where they compared Clozapine and Olanzapine, another very effective second-generation antipsychotic, finding that Clozapine was better than Olanzapine in a variety of different outcomes that can be related to suicide, apart from other things, suicidal behavior, hospitalizations, use of rescue interventions, use of ED visits, and virtually any outcome that you can think of. So Clozapine is currently typically used in people who have either schizophrenia or schizoaffective disorder and are deemed at high risk of suicide. We also have SSRIs, selective serotonin reuptake inhibitors, which are medications that are widely used for anxiety, for depression, and for many other disorders in psychiatry. And there is a lot of they are thought of being potentially effective at lowering suicide risk, mainly because there is a theoretical basis for this. There is a big body of evidence showing that people who are suicidal might have neurobiological differences in the metabolism of serotonin in the brain. Also, because suicide risk is typically high in people diagnosed with disorders that can be treated with SSRIs. So we need to think which SSRI might be the best. And also because SSRIs, as opposed to other classical antidepressants, are safe in overdose. At the same time, there is some evidence that SSRIs have different effects on suicide by age group, and actually SSRIs in the US come with a black box warning in the box because there might be an increase in suicide risk among youth when they start using SSRIs. So this shows, as you can imagine, a very complex picture for use of SSRIs. And overall, there is a lack of evidence, lack of randomized trials of SSRIs for suicidal ideation. There's one main study comparing paracetamol with bupropion, which is not an SSRI, and showing no effect, again, on suicidal behavior. And last, in terms of bipolar disorder and also unipolar disorder, unipolar depression with that is severe and has suicidal risk, there is a lot of evidence about use of lithium. So lithium is a long-standing recommendation in the guidelines, and most psychiatrists use lithium for people who are bipolar and, in general terms, especially if they have suicidal ideation, and also for people who have unipolar depression and might be experiencing suicidal ideation. This comes mainly through a big body of trials, and there's this landmark, again, meta-analysis that has had different iterations over time in different journals by Cipriani and colleagues, where they show that in terms of suicide deaths, although there are very little outcomes in the individual studies, in terms of suicidal death, using lithium might prevent risk of death as compared to placebo in people who have either bipolar disorder or unipolar depression. Interestingly, there's a recent, many of you might know this, there's a very recent meta-analysis that has called this finding into question, mainly through introducing new studies that were published after the last iteration of the Cipriani meta-analysis, and also by including previous studies that had zero outcomes, and also by excluding papers that were published before year 2000. And so there's differences in the inclusion criteria and differences in the studies that were included. And this study has found that there might be no effect of lithium as protective for suicide outcomes, both for suicides and for non-fatal suicidal behavior. However, when they do include the studies published before year 2000, the effect goes more towards finding an effect, a positive effect. So Alejandro is going to continue now talking about specific studies that have been published after the Cipriani meta-analysis.
Thank you. So what I'm going to do next is briefly go over the latest randomized trials. And just to be clear, these latest randomized trials, they specifically look at the effect of lithium in preventing suicidality, not suicide, because as it was mentioned, it's very hard to study with the sample sizes that are usually present in randomized trials. So the first pragmatic randomized trial was published in 2000, that I'm going to go over is published in 2011, and patients with bipolar disorder were randomized to either lithium or valproic acid, and as I mentioned, the primary outcome was suicidality instead of death by suicide. And to be clear, suicidality is a composite outcome that includes death by suicide, but also suicide attempts, hospitalizations because of suicide, but also medication changes in response to suicide. And the results were compatible with no effect of lithium at the end of follow-up. The same was present in another randomized pragmatic trial in 2008 by Clozapine collaborators, but in this trial including bipolar disorder, but also patients with major depression. The outcome was also suicidality in this case. And there is another trial conducted in 2014 with similar procedures and similar results. And this all led to a situation in where investigators at the Veterans Health Administration decided to conduct another large randomized trial in the VA population, trying to put an end to this controversy and trying to find whether lithium actually prevents suicidality or not, and randomized 500 patients with bipolar or major depression and a prior suicide attempt to either lithium or placebo. This is, to this day, the largest randomized controlled trial conducted on this topic. The primary outcome, as in the previous randomized trial, was also suicide-related event, that is, it's not only death by suicide. And the results after 1 year were also compatible with no effect of lithium at the end of follow-up. The hazard ratio was 1.10 and a 95% confidence interval from 77 to 1.55. It is important to say, it's going to be relevant after, is that the trial was stopped for futility after 500 patients were enrolled, and this was because the data monitoring committee had proposed an alternative hypothesis of a 10% risk reduction at the end of follow-up and a hazard ratio of 0.34, which was very far from the interim intention to treat analysis that was conducted. So on the basis of assumptions about future event rates, the trial was stopped. So this led to this situation in which there is a huge discrepancy between clinical intuition and the result of these recent randomized trials. And the reason for this discrepancy is that clinical intuition for most psychiatrists is that lithium actually works in preventing suicidality, but this is not shown in these recent randomized trials. And there were many explanations proposed as to why this discrepancy exists. And I'm going to focus my attention on low adherence to lithium as one of those explanations. And that explanation actually makes sense because the intention, all these trials were analyzed using the intention to treat analysis, reporting the intention to treat effect. The intention to treat effect is the effect of being assigned to the treatment strategies, regardless of what they do after baseline. So in the presence of significant deviation from protocol or non-adherence, if the treatment has an effect, that effect is going to be closer to the norm than the actual effect of treatment, and this is because it's going to be diluted by non-adherence. And in fact, there were significant non-adherence rate in all the trials that I described, reaching to over 80% of non-adherence in the CATS trial, in the BA trial. So this is why the per protocol effect is much more relevant in this case. The per protocol effect is the effect of adhering to the strategy throughout the entire trial. And because the BA trial was stopped for futility, it is even more important that we know the per protocol effect in that context. So what we did here recently at the CAUSALab was try to estimate the per protocol effect of lithium in that CSP 590 trial, in the BA trial that I reported. And so the way that we conducted the per protocol analysis is that instead of censoring individuals after they show non-adherence, we actually define non-adherence if the treatment is stopped unless there are clinical reasons for that. And in the second step is that after censoring patients for showing non-adherence is that we conduct the analysis in the restricted population of the trial who showed adherence throughout the trial, but we have to adjust for confounding in that population because we have broken randomization. So this is what we did in the analysis. In the first step, we allowed patients to show non-adherence. We allowed patients to show non-adherence if there were signs of severe toxicity or clinical reasons to stop treatment. And in the second step, what we did was adjust for baseline and post-baseline confounders. And we did that using inverse probability weighting. So this is one of the main findings, is that the predictors of non-adherence were unevenly distributed between treatment arms. For example, patients in the placebo arm who had markers of severity, such as bipolar disorder or high intensity of suicidal thoughts, were more likely to show non-adherence. And this was the case because more than 70% of people in the trial were able to correctly guess what treatment they were assigned to. And this is because lithium is very hard to conceive as a treatment. So patients knowing that they were assigned to placebo and having more severe markers were probably more likely to stop adhering to the strategy. And so the results after censoring for non-adherence, that is after we stop considering events that occur after there is evidence for non-adherence, we show that the two strategies are similar to each other with the relative risk close to the norm. And then after adjusting for baseline and post-baseline confounders, what we find is that actually the effect flips. And now lithium shows a protective effect against suicidality at the end of follow-up with a relative risk of 0.24 and a risk difference of 7 percentage points. Of course, the confidence intervals are very wide, but the point that we try to make is that the confidence intervals are also compatible with the limits set by the data monitoring committee. That is, the confidence intervals contain the alternative hypothesis that was set by the data monitoring committee. So there are two findings that merit discussion. The first is that we do see that patients who deviated from the protocol in the lithium group were more likely to suffer suicidality than patients who deviated from the protocol in the placebo group, which drives the first change in the effect that we see. And an explanation for this can be found in literature where there's a consistent report that patients who abruptly stop lithium suffer abrupt clinical deterioration and increase in suicidality. The second finding, I think it's more intuitive, and it's that after adjusting for these prognostic factors, we also see a more protective effect of lithium, and this can be explained because in the sample of patients who adhere to the protocol, overloaded the lithium arm with patients with baseline markers of severity, such as bipolar disorder or higher intensity of suicidal thoughts. The last point I want to make is that based on these randomized trials, especially in psychiatry, especially in this context where there's such a low adherence, they should incorporate per protocol effects, especially in the decision-making processes for stopping trials for futility, and also that the estimated per protocol effect of lithium on suicidality is compatible with a protective effect, but we do realize that the confidence intervals are very wide, so we propose further research with larger sample sizes in the future. So, thank you.
Thank you so much. So one brief comment. It was mentioned that there can be challenges with maintaining adherence to these medication strategies, and you just showed the advantages of a per protocol analysis, which we can do in both a randomized trial and an observational study. And then observational studies also offer additional advantages of maybe looking at lower incidence events like suicide, death itself. So maybe during a panel discussion, we can expand more some of these opportunities and challenges of using, say, large health databases to study the effectiveness of these meds on suicide outcomes.